So I think sequential segmental analysis, Kiran has already mentioned. And if you're doing the TE or somebody who is doing the intervention needs to know that if they have any associated lesions, do have an interrupted IVC, then there is no point in going from the femoral vein. Very important. So you need to know about the associated lesions. If intervention, you need to know which type. You need to know whether transthoracic gives you the better idea or transesophageal will give you the better idea. Pre-assessment, very, very, very important, and intra-op assessment. Okay. So I always look at it in the transthoracic. I make sure IVC is uninterrupted because that's the first thing. So if your IVC is interrupted, then the whole procedure is gone if you're doing interventional based modalities. Okay. As I said in the ASD, there are different types of atrial septal defect, and this is what we are talking about for the device closure, because this is in the middle and this has borders, so the device will hold. If it is sinus venosus, then the SVC border is absent. If it is inferior sinus venosus, IVC border is absent. And similarly for coronary sinus defect, when the whole defect or the whole of the rim is absent, then you will not be able to do it. Okay. I sometimes draw. I'll just draw it here. See, for me, if I'm doing an ASD, my IVC comes here, SVC is here, RUPV, my aorta is here, my coronary sinus is here, my AV rim is here. So that forms the 360 degree, and then there is a posterior rim. You have seen how the device looks like. So I divide it into 60 degrees each rim, around 6 rims. So if the IVC rim, only 30 of it is absent, let us say the rest of the rim is there, the device will still hold. So not seeing the rim in one plane doesn't mean that device is not going to hold. So if the rim is absent in one plane, you move your TEE, rotate it clockwise to anti-clockwise to see in 60 degrees, is it there in any part? If it is there in any part, it will still sit. But however, if it is totally absent, like it is in sinus venosus defect or the IVC type defect, there is no point in attempting ASD device. Now this is a very good ASD if you're considering device closure. It is in the center and it has good borders. So this is what we call as perfect ASD. There is, good margins and it is a smaller defect. And again, there is different nomenclatures, and for me, I've been taught in a way that you name the structures around it. Very easy if you say it is a right upper pulmonary vein rim, IVC rim, SVC rim, rather than say it is inferior rim, posterior rim, antero-superior. I don't know what they tell then. Okay? If I know CS rim is present, mitral rim is present, aortic rim, plus or minus, it is okay. You can still do the device, RUPV rim. So 5 to 6 rims you need to know, and better by the name. And nowadays, we have 3D reconstruction. In adults, it is very useful. One of the things which is important in TE, if you're doing the structural thing, is the surface area alters significantly between systole and diastole. So your sizing matters. Where do you take it and how do you take it? And it is an irregular. So that is very important. Okay? So people a lot of the time fail because they have set ASD as 22 millimeters on the TEE, but it is not in the maximum diastole. Okay? So then if you take a 24 device, it is never going to sit. Or if it is going to sit, it is going to, the chances are that it will embolize. So you need to take the diameters properly. I'll just skip this because I think the time is the essence, isn't it? I think in some cases, I'll just show you a brief. This is transthoracic, but you get in the transesophageal as well, the IVC rim is deficient. The SVC is coming from the top. This is like a bicaval view which you get. So the IVC rim is almost absent. So this is I would probably say better for surgery. So if you're doing your intraoperative assessment, then this is what you need to look for. You need to look for IVC rim. You're making sure that it is not a primum defect like this. where there is no anterior-superior rim. That is an endocardial cushion defect. And this is the sinus venosus ASD. There is no SVC rim. This interatrial septum is overriding the SVC. So no device is going to sit there. Okay? And there is usually PAPVC of the RUPV, abnormal drainage of the RUPV to SVC RA junction. Few people have used covered stent in this area. So it is possible nowadays to close this by intervention still, but you should have made your assessment pre. So you can put a covered stent as long as the RUPV is draining into this thing. We have not done it here, but people have mentioned that. So once we have put the device, as I said to you, we do the wiggle to make sure that the device stays in place. Okay, so we are wiggling it here to make sure device stays in place. These are all transthoracic images because all our cases we do it under transthoracic guidance, but the same wiggling would be done in the transesophageal. So we look at different ways. Sorry. And then when we feel safe, we release the device. Now, I said the 3D is very useful because this is a fenestrated ASD. Now, you can see that there is a larger hole here, a lot of flimsy rims. So if you're going to close this defect, then you should be crossing through the major hole. Otherwise, you will never be able to close the defect. These are the only ones I regularly use TE at present. Very important, so that I go through the main defect. And if you have gone through the main defect, we did one 2 days ago as well. So then it is used, it is much easier. If without TE, we couldn't do that ASD otherwise. Ventricular septal defect, similar. Do you have time or let me finish faster? It is? Okay. So what is important to know? One is the phenotypic features of the defect. What are its location and what are its borders? The number of defects, very important to go up and down, anterior to posterior, left and right to see if there is any additional defects. When usually people see one defect, they forget that there can be multiple defects, and that's when we go wrong. Is there any associated malformation? Is there malalignment? Is there RCC prolapse? And for me as an interventionalist, if I'm doing VSD, then it is important to know the conduction tissue in relation to the defect, whether I'm going to cause a heart block or not. So when I say ventricular septal defect, people have different way of naming the ventricular septal defect, but I have been taught in a different way. So you look at it from the RV side, and then generally, broadly, divide it into 3 groups. One which has exclusive muscular borders. So that is a muscular VSD. It could be an outlet muscular VSD, anterior muscular VSD, posterior upper muscular VSD. It could be a mid-muscular VSD or apical muscular, but it has muscular borders. The next one is and that is very important because a lot of the time people write subaortic VSD. Now, what do you mean by telling subaortic? All the VSDs should be below the aorta. Otherwise, it is different. The only time I use subaortic VSD is in relation to double outlet right ventricle, because then when I said subaortic VSD, the surgeon knows that he's going to be able to tunnel the aorta. Otherwise, you should always name the VSD. The other ones are perimembranous ventricular septal defect. There is fibrous continuity between the aortic and the tricuspid valve or the AV valve. And the last one is doubly committed subarterial VSD, where there is fibrous continuity between the aorta and the pulmonary valve. So for us doing structural interventions, these two, we do close it with the devices. We don't close this because if I close it with the device, then I will either hold the aortic valve or the pulmonary valve. People have been using different, slightly different devices, but I still think when you have an alternative, which is surgery, which is fantastic, we shouldn't touch it. If you're doing any intervention, it should be good or better than the previous procedure. Otherwise, you shouldn't do it. And even the ASD, when I do it, I tell to a lot of people, if there is a safe surgical procedure, If you think that is very high risk, don't do it unless the patient party really wants you to do it. So I'll just go to the TE pictures if I have. And this is what we look at during the transthoracic echo. We see the ventricular septal defect, and we see whether we see the defect at the level of the aortic valve. I know that it is slightly away from the aortic valve. So I look at all the VSDs and other things myself as well. And this is one typical where you have fibrous continuity between the aortic and the pulmonary valve. So this is a doubly committed subarterial VSD. So there is no possibility of a device closure here. And even otherwise, the surgeon needs to know it because they approach it differently. I'll see if I have. Okay, this is one of the cases from the TE. We do some of the hybrid procedures now where there is open sternotomy, and if I feel that we can close it with the device, then we do it with the device closure. So all we do is we just make a nick through the heart, through the right ventricle, and then cross it with the wire through TE guidance, and Dr. Keshavamurthy is usually there, and then through the introducer sheath, just as I showed you now, we do the device closure. We have done about 35 now, and then when it works, it is fantastic because there is no bypass. It finishes in 10 minutes. Okay, so we see where the VSD is, and then through the TEE, we are seeing the position of the device, where it is. And then you have released both the discs. Can you see that? 2 discs, and you can see it quite nicely. And then you release it. So this was an outlet muscular VSD, which was through the hybrid procedure. Similarly, this is from the angiogram. This one is not working, is it? Okay, let's forget it. You can see that we are releasing the second disc. We have the pigtail catheter in the left ventricle, and this is, we do it percutaneously. So again, in most of the centers, they do it under TE guidance. We have done a lot, so we are not doing it under the TE guidance anymore. And then you do the angiogram, you see the hole is completely closed. Okay, so the percutaneous device, we have done about 450 VSD devices here in the last 7 years. And this is similarly a mid-muscular defect. These are all small children. These are 3.5 to 4 kg children. Okay, so you can see the large mid-muscular VSD here, and we are looking at the TE from different planes, and you can see the wire has gone through. So we pass the wire through the TE guidance. Okay, and once we have passed the wire, we pass the sheath through the VSD, and we have released the first disc. And that is very important. That's the reason TE is important for me, because I don't have a fluoroscopy, so I need to know where my discs are. I need to make sure mitral valve has not been caught. So a lot of structures to think about. When you're doing the VSD, that's very important for whoever is doing the TE to make sure that the mitral valve is okay. And then now see, we have released both the discs. VSD is completely closed. Okay, so this will become sort of usual procedures for a lot of you, because interventional cardiology and hybrid procedures working with the surgeons will become quite common for a lot of ventricular septal defect. This is a post-infarction VSD. Okay, so there is a large apical VSD with reduced function, and you can see the VSD here, completely torn septum. So in adult, these are very difficult ones to close. Again, as long as you have done, and you have seen, you can see the VSD here. Okay, as long as you have looked at it, see, I have looked at the size even before, what device I will be taking. So your TE will help you extensively. And once you know, I'm not going to go through this wholly because it is a long case. So that on table, they will have pulmonary hypertension. post-infarction patient. They are in pulmonary edema, they have pulmonary hypertension, very difficult cases because they'll not be able to lie down for you for a longer time. So we approach through the neck. So everything should be ready, you put the TE probe, and you should finish your case within half an hour, 45 minutes. But quite satisfying because the PA pressure falls on the table drastically to 1/3 or near normal. And the patient in the next 2 days will come and tell you, real thanks, because there was no other procedures for them otherwise. And this is the device in situ for him after the procedure on a transthoracic echo. I'm going to skip this. This is not needed for TE. This is also not needed. But there are many other. Yeah, it is quite useful if you have an AP window or if you have a ruptures of sinus of Valsalva. TE is very essential if you're doing the device closure. Now, this is a case of ruptured sinus of Valsalva, which you can see here. Okay, and these cases you really need the TE because you want to make sure that you are in between the commissure and you have not caught the cusp. So you should be, that's very important. So wherever you're putting the device, make sure the surrounding structures are fine. The tricuspid valve is okay, the aortic valve is okay, the mitral valve is okay, because you cannot cause another lesion by trying to close something else. If it is not, they should go for surgery. Okay? I think I'll stop there. I think that's the major sort of idea behind TE, but it is becoming quite common. A lot of cases are done through intervention now. It will only increase mitral clip and so on. So TAVI process, so it will only keep increasing. Any questions?